Hi, this is Cousin Consults. I'm Dr. Kendall Moore.
And I'm Dr. Durrani, and we are super excited to be joined by my friend Em Shone, a GI and breast medical oncology registered nurse, an influencer with thousands of followers, and someone who is my go-to for all the hot takes on the Pitt. Welcome to the show.
Thanks for having me, Waze. I appreciate it.
Absolutely. Your threads, live threads post during the show are fire.
Thank you. I appreciate at least someone's reading them.
Yeah. What tell us about how you got into the show, like season 1. Was it something that you initially you were day one, or like you saw the award nominations come in and you joined, or when did you get in?
I wasn't necessarily day one. I think someone had mentioned you should probably watch this, and I was like, okay. And then a couple episodes were out, which is nice considering all the cliffhangers. But I watched the first episode halfway through, and I was like, I don't know if I really am into this. And then I gave it a full episode and I couldn't stop. And ever since then, I watch it literally, I think it comes out on HBO Max at 8:01 p.m.
Yeah.
Texas time. And that's when I watch it.
Yeah. It's been we talked about this before, this season's weird because we're doing this podcast, we are watching every week, and it's weird because you have to wait. And then when you are watching it, you're almost thinking of it as like taking notes of oh, what scene do we want to talk about or whatnot. So it's different.
Yeah, for sure. We're watching it differently before. I'm a binge watcher, so it's kind of hard waiting for week after week for it to come out and see what happens next.
Absolutely. I'm the same way.
Well, tell us more about your day-to-day before we get into our scenes. What kind of environment do you work in? What kind of patients do you see? Were you in a different field of nursing before this or not?
So I have always been an oncology nurse. I've been an oncology nurse for over 8 years now. I started bedside like every nurse does. And then I actually went travel nursing, and I worked outpatient. I worked at Sloan, was my first outpatient contract. I worked in GI, and I loved the outpatient hours. I really liked the clinic setting just because you spend a little bit more time with patients, and you don't have to do physical labor that comes with inpatient nursing. But I ended up out here in Texas because I got a job at the best cancer hospital in the world, and I couldn't say no. So I work in an outpatient clinic now, and I work with breast and actually liver cancer patients. I see patients with the providers, and then I, do a lot of admin work on the side. Do a lot of insurance issues and triage phone calls.
Yeah, one of my curiosities, and we'll actually get more into this with one of the scenes that we're going to see, is that. Obviously cancer is a word no one wants to hear. It's a very scary word. And usually with us, it's they either know already or we're the first ones to break the news to them, which is also very shocking to them. But you're with them when they're on that journey of treatment and, trying to get better and whatnot. And to someone maybe not involved in that day-to-day, they may think of it as a job that takes an emotional toll on you. How does it? And I imagine it probably does. How do you deal with that? And how do you get through that? And I know a lot of people work in that environment. How do you all kind of cope with that?
Yeah, that's a really good question. I think, for us, humor is everything, right? I think people who work in healthcare have the darkest sense of humor, but it's also the best way to cope. And definitely laughter is the best medicine for me. I'm always laughing at work. I'm always trying to keep the vibe positive at work. I'm high energy. But yeah, oncology is one of those fields where it's, it can be more depressing than usual just because of the nature of cancer itself. But I actually went into oncology, oddly enough, because of the death and dying aspect. Hospice and palliative care. Well, really, palliative care is actually my true passion. And I was fortunate when I first started in the bedside. I worked on a floor that had both oncology and palliative services running hand in hand. So I learned a lot about that aspect. And when I worked there, I was my first week. My preceptor told me something that completely changed my perspective. And she said, for a lot of these patients, death is a release of their suffering. So ever since that was my first week as a nurse, right? As a new grad nurse. And that completely changed everything for me. And now, I see being there with a patient, as they're navigating this cancer journey and, navigating the difficult aspects of, transitioning to hospice. That's my favorite part. Helping them realize that, this is an inevitable part of their journey, but helping them come to acceptance is I think is the most beautiful thing.
Yeah.
Nice. To pivot off that, I was watching some of your videos, and I remember like two videos. One where you're like 30, but I feel like I'm 59 and half ready to retire, or I'm coming back to work as a threatening to quit. So burnout's kind of like a real thing we talk about in healthcare a lot. Like, what are some of the things in your workflow in healthcare that kind of burning you out? It makes you feel like there's a big burnout rate in medicine.
I think, there's a lot of administrative burden that comes with healthcare. That takes time away, the providers away from the bedside. And for me, I chose to go into healthcare to work with patients and to, especially in the outpatient setting, to have to deal with insurance companies all the time and to have to fight them, for basic care for these patients, over and over again. I think that's a really big source. And also just, not getting the recognition that we deserve, and especially after COVID, getting insulted and getting almost threatened to do, doing the same job that we were doing prior. That's a huge source, I think.
Yeah. Where did social media come into play for you? How long have you been, posting on social media, and what was like the first thing that prompted you to do that? And
Sure. It was actually during COVID. I like OG TikTok was starting to do like TikTok dances.
Yeah.
And again, it was really to keep the mood light. I used to do them. I'm probably gonna get hate for this, but doing it on the floor itself. We would do it after when the shift was ending. But it was really just a way to keep things light, keep people laughing. And then it became something more for me. When I was a travel nurse, I had a lot of free time. And I noticed there was a big gap in the oncology field. Not a lot of oncology nurses out there, and not a lot of oncology information, particularly for nurses. In nursing school, we get like literally a line, like oncology nurses get chemo. That is it. And so I started doing a lot of education videos about that, and that's how I really found my passion. Like now I combine both, right? I try to be funny and also, educational in the content I create.
Yeah. One thing that I'm usually curious about, and I think a lot of people probably are that are not medical, is like med school. Everyone knows, like, you go to undergrad, med school, residency, the journey to become nursing. Like I know at UT you could get a nursing degree, but you can get other types of nursing. Like you can join nursing programs to like community colleges and then transfer to. Tell me about what that journey looks like for you, and then like what other paths are, because a lot of people get confused. They see like RN or other like 3-letter words or 2-letter words, and help us understand some of that.
Yeah. So. There are many routes to become a nurse. My route was actually non-traditional. My first degree was in biology. I thought I wanted to be a doctor. I did the whole pre-med route. And then I actually failed my MCAT. And as I was retaking it, my dad was always in my ear saying, "Hey, Emily, like, why don't you want to be a nurse? Why don't you be like, a PA? Like, why do you have to be a doctor?" And I couldn't give him a good enough answer.
Yeah.
And as I also was working, coincidentally, in the emergency department, doing research at the time. And that's when I realized that, my heart was more with the nurses because they were with the patients a little bit more. And that's when I decided to go to nursing school. So I did an accelerated program. So for people who have a bachelor's degree in another field, it doesn't have to be anything science. Like my best friend is a nurse when we went to the same program, and his first degree was in film and television.
Yeah.
And it's usually like, less than 2-year program, similar to community colleges. But you come out with a bachelor's in science and nursing. But yeah, there are different routes. You can go through community college and become an associate degree nurse. Who I know there's a lot of debate right now about associate versus bachelor degree nurses. We take the same licensing exam. We come out with the title of registered nurse. It's just bachelor's degrees nurses have to do a little bit more, I think, like statistic work and stuff in school. Then there's like LPNs and LVNs, which I actually didn't know about until I transitioned to the outpatient setting. I think they're used a lot more in that setting. We were getting a little bit of exposure to LPNs during COVID, just because there was a nursing shortage, like an RN shortage, I'm sorry. But their scope of practice is a little bit more limited, especially in oncology. They can't give chemo, but they're definitely valuable members of the healthcare team for sure.
Yeah. Sure. Did you kind of understand that path, or for me, it's always been like, and I understand it now. I'm like, oh, that's what those different pathways are. But
yeah, I know people. My nurse, my sister's a nurse.
Oh,
I
so
know.
yeah, you knew.
And even like in the ER, we have some LVNs, LPNs as well. Because sometimes you ask them to do certain things, they can't give certain meds.
Yeah,
and when
that's
we
true.
have the RME section, they kind of are there like drawing labs and everything, but they can't give a lot of medications.
Yeah.
You don't know until you ask them. They're like, "Oh, I can't do that." You're like, "What do you mean?" And they tell you why.
Yeah, that's when I first realized it. I was just like, oh, everyone's like a nurse, right? They can help you with this. And it's like, oh, I can't give this med. I was like, oh, interesting.
Yeah, I think it's all like just controlled medications. But at the end of the day, like, the N, whether or not you're, registered nurse or an LPN, we're all nurses.
Yeah.
But yeah, it's just that scope of practice with medications is a little bit different.
Absolutely. What, like with the show, The Pitt, from my perspective, I think they do a great job of like showing how important nurses are and how like they just couldn't function without them. What is your impression, just as a general kind of been of your profession being shown on that show?
I think the respect that Robbie has for Dana is so important. She's the queen. She's the boss. Like, I love when he does that, because it is. Physicians really can't run. Floors can't run units without nursing assistants, right? And it runs a lot more smoothly when you have mutual respect for each other. But actually, my favorite part of The Pit is because this is such a real thing, and like, unless you work in healthcare, you really don't know. But nurses are huge gossips, and the fact that they portray that on the show as well is so iconic to me. I think that is so funny and that is so dead on.
Yeah, I think like the hospital we work at is well staffed, but I work at some rural places and whatnot, and maybe they're not as well staffed. And when you really realize that you can't do anything without nurses, is like you get a crashing patient, you're in the room, you're like, I want this med and this med and this med, and then the nurse leaves to get the med, and like they're the only nurse there, and you feel helpless. You're like, oh God, I can't do anything without the nurses.
Yeah, that's one thing. We don't have access to the PICs. We can't get.
Yeah, we can't get anything. Yeah,
That's actually really funny.
Yeah. Awesome.
The PICs is a way to get the medication at, for people don't know. It's where the medication is locked up at. So
yeah. What season 2, you've been what stood out to you so far? July 4th shift.
I think seeing the characters change a little bit, especially I loved Whitaker. He was kind of like last season was getting dumped on, just the classic kind of first year resident type situation. But this season, he's actually coming into his own, and he's like, educating other residents. And I think that's so fun, and I love that. And I also love Langdon's return. He's one of my favorite characters. And to see, him apologize to Louis is amazing. And I think his scene with Mel, where he, apologizes to her as well, one-on-one, that's kind of really stood out to me.
Yeah. Awesome. Well, let's dive into the clips. We're going to play your clip first, and let's discuss.
I'm sure you have some questions. I know it's a lot to take in.
It's a tumor. It's a brain tumor.
Well, it's a mass. About 4 centimeters in the frontal lobe.
Is it cancer?
We can't say for sure right now. It could be many things. Infection, inflammation, a benign cyst.
Is it what made me fall?
Yeah, possibly. We'd like to keep you here and treat with dexamethasone, which is a steroid to take down the swelling. And then we'll need a brain biopsy to know exactly what it is.
You're gonna cut open my head.
It's just a small hole. We'll do a CT-guided stereotactical biopsy with a blunt, thin needle, which sounds crazy, but it's actually pretty amazing. I mean, most patients go home the next day.
I don't know. What do you think I should do?
I think this is a pretty good plan.
Okay.
Powerful clip.
Definitely.
Tell us about why you chose it.
I chose it because, obviously, as an oncology nurse, like when the word cancer pops up, I listen. But also, I think it does a really good job of showing kind of, the humanity behind delivering these diagnoses. And I don't know how you guys do it. Like, obviously, this part of my field, but we also have a lot of time, right? We can dedicate an entire appointment to delivering a diagnosis of cancer, right? You guys have what this clip was like 90 seconds,
Yeah.
right? Like no time. So it's really poignant to me. And it's also interesting because, he's automatically assumes cancer. And she's like, it doesn't have, we don't know yet. And I think that trips up a lot of people too, because the word mass is scary. But there's a lot of explanations for that. It could be benign. So that's why I picked the scene. It's just, there's a lot,
Yeah.
It kind of like you're saying, like you can dedicate a whole team. Sometimes we're coming in and tell them, and I mean they'll come in for cough, just the most random things, and we have a lot of incidental findings. And like she's kind of telling her, it's a mass. We don't know what it is until you get a biopsy and see. And then the person, everyone thinks cancer when you hear mass, so it's kind of always uncomfortable to have these conversations. We do it a lot. Be honest, sometimes we don't right, sometimes we don't. Sometimes you say cancer, you should stop and give a break and let them process it. Sometimes you keep going and you don't realize that you keep going and you haven't given them a chance to process what they've just heard. But it's a difficult conversation, and again, it's kind of hard for me to make the diagnosis. You need to get a biopsy. You need more of a workup. It's not done yet.
Yeah. Yeah. So that was our engineer here who was just saying how his friend was involved in a bad motor vehicle accident and showed up, and unfortunately his friend passed away, but they obviously scanned him as well and they found cancer, and they were looking for trauma, obviously not cancer. But in this scene, it's really it's hard to say, but unfortunately sometimes it's even more rushed than that, right? Mm-hmm. Like you may literally go in there and be like, oh, you came in because you thought you had pneumonia, but we scanned your chest and there's this mass and it could be cancer. And right as you're saying is the nurse may come in or someone else is like, hey, we have a CPR coming in 3 minutes. That takes up the next 45 minutes of your day. By the time you come back and you're like, oh, let me go back in there, like, oh, they left already, or they didn't want to wait, or whatever the case may be. And it's just like, I like right now when I'm like putting myself in their shoes, like that's just terrifying, right? Someone told you this news that's like life-changing, and then you have to like, it may be a week, it may be 2 weeks before you see the specialist, before you get the scans, and that's just difficult.
Yeah, I think with time you get better, man. I think, like I said, early in my career, that was me. I would say, hey, found this mass, and I'll kind of keep going instead of giving them time to process. And then, I mean, someone actually corrected me, like, hey, give me a second, let me think about that. And I just had to think, like, oh man, let me take some time, let them think about that. Come back and talk a little bit later about it. But yeah, it's kind of rough delivering that news. I just met this person; they're here in the ER for something, and you're telling them this. I don't know them. I maybe never see them again. So.
Yeah, I mean, honestly, it's my uncle. He found he had liver cancer. Thankfully, he's alive. It was surgically resected. But I remember getting this call from my parents, and I'm the only person in my entire family that's medical, like extended family, anyone. And I knew it was serious because my mom called and then my dad called right after. And they just, when I answered the phone, they said, your uncle has metastatic cancer and he was told he was going to die. And I was like, what is going on? And it turns out, so he had gone, my aunt, his sister, had just died of cancer. And he used that event to, he'd been having abdominal pain, nausea, some like general symptoms. Went to the ER, ended up getting a scan, and they saw a mass. And that's what apparently a nurse told him, which I don't know, this is definitely not true. But someone came in to tell him, you have stage 4 cancer. And then that was it, because they also saw a nodule in his lung. But that was it. And I was so stunned, but, also thinking this was kind of, during COVID as well. And I was like, how many other patients, did they have to see? And I know oncologists, that are trained to do this, that still make the same mistake of not pausing and allowing patients to process, right? And I think that's where nurses are really kind of coming, quote unquote, in handy, right? We're able, when the doctors see multiple other patients, we can sit with the patient and be like, how can we help you process this? But I still don't know how you guys do it. Like, it's always been a life-changing thing. Like, like people hear the word cancer and the world stops. But your guys' world certainly doesn't stop.
Yeah.
Like you could have someone who just died next door and you have to just snap out. So I applaud you guys for doing what you do, even dealing with something as crazy as this.
Yeah, for me personally, there's very few things that kind of give me that pit in the stomach of like, oh man, I don't want to do this. One's like, obviously when someone passes away, updating their family that doesn't know yet. And close after that is the cancer, like having to go to the room. Like, I'm like, oh man, let me do this other thing before I do that. Cause it's just like, oh my, like I know that entire reality is going to change and it's just like nothing you can do about it. Mm-hmm. if you were like giving her advice, would you say she could have done anything better in that 90-second clip? Like, obviously, unfortunately, she doesn't have the luxury of time, but would you give any critique, or you think she handled it pretty well there?
No, I think she handled it so well. And I think she explained, even the fact of a biopsy, a brain biopsy is really scary, right? Because most people think, you need to cut open. But I thought that piece was so perfect too. She really just took the time to be there, sit eye to eye with the patient and deliver this horrible news in a way that he could process, even though, his mental state is obviously kind of frazzled to begin with. But no, props for Dr. McKay in this scene. 5 out of 5.
We don't have rooms all the time. We do waiting room medicine a lot, and so sometimes you're telling people, and it's like a curtain here. You're trying to like whisper, and it's just like, it's a family room open, but it's not, and so we always have room to tell people sometimes too. It makes it awkward. So I try to wait till we have somewhere to secure to tell them. Don't just tell them in a crowded room or anything. Yeah.
But sometimes it's like, oh, you should have told them half an hour ago, or maybe like with now, their CT results will populate on their phone before you even get a chance to tell them, and then obviously they see the scary words there of a mass or tumor or whatnot, and even that's like bad sometimes because like they see it and then they have half an hour of like questions and like complete fear and whatnot, and you can't get to them because they're not in a room, they're in the waiting room, and we're waiting to bring them back, and that's just the reality of healthcare in America in 2026.
I think everywhere. Yeah. Everyone's doing waiting room medicine now.
Any final thoughts on this one?
No, I think, the scene after where the wife comes is also very poignant.
Yeah.
Her being his healthcare proxy, and her, realizing that the whole, his mask could have been the reason why his behavior changed. I think it was just a really good arc, and I really liked that.
Yeah. They showed how the best possible circumstance in which this could have happened. Obviously, it's never a good circumstance, but everyone handled it the way that it should have been handled. The other thing that's and I completely lost my train of thought. I was going to say something, and I totally lost it.
We'll edit it back in.
Yeah. Okay, this is going to be Kendall's clip.
Quit playing family pharmacist.
Pooling meds is how we've always done it. You put everything in a big pile in the middle of the table.
Well, look where that got us now.
No, I'm going to jump in here and echo that sharing meds which haven't been prescribed to you is actually a real big no-no. Well, how are we doing on remembering what your brother might have taken?
We could call back to the house.
Great idea. Okay. Whatever.
Okay, Leo, can you zoom in and please hold it a little steadier?
Okay.
Okay. Atorvastatin, simvastatin, ezetimibe. Those are all high cholesterol medications. Can you go to the right? Lisinopril, losartan, propranolol.
Wait. That's it. Wendy's pile. Yellowish bottle.
It's almost like it's like the Mars rover, and they're like on Earth, and it's like they're in space, and like, oh, it's that thing. Why'd you choose this?
Well, so I chose it because I don't know why they were pulling med. I thought they were like a big racing family, so I thought they all should have insurance, but maybe not. But like, it's a real thing that happens. So, but they put them all in the right pile. Hell, all the cholesterol medicines here, all the blood pressure medicines there. But it's a real thing that people do. Sometimes you don't have insurance. You borrow some of your buddies or some of your family members, but it's kind of ironic that Lane is the one telling people don't take other people's meds. But it's like you have to do what you have to do sometimes, which is not always the best. They're not doing it just to get high or get some high. They're doing it to try to survive. They have high blood pressure. They don't have access to a primary care doctor or insurance, so they may just borrow their neighbors, their family members, their elderly mother or someone's medication. But what you need to understand is that just because your sister or your mother takes the same medication, you may have a different reaction to it. Like this guy was taking propranolol, was a beta blocker. His heart rate slowed down probably, more than what his sisters probably did, and lead him to be in the hospital. So you got to be careful with that. But I understand why people do it, because they're just trying to survive and try to be healthy. Actually, trying to take care of themselves the best they can.
Yeah. It's one of the most common things that we hear, and you probably hear too, is like, I had like a sinus infection. I had like some of my leftovers, family members, Z-Pack or something that I took. And usually that's like a benign situation. Usually nothing bad happens, but obviously in this case, when we're talking about blood thinners or blood pressure medications, like it could kill you literally.
Yeah, my favorite part of the scene was like I took 5 of them.
Yeah.
Oh my god.
Yeah, that makes no sense.
I was cracking up. Like this whole scene was just.
But you know what? You probably took 5 because she saw I'm twice her size. I'm gonna take twice her. She takes 5. That's probably what he was thinking though. But also, it's not benign. You take someone's antibiotics, right? It happened before. This guy has a sinus infection. He takes amoxicillin for 2 days. It's not the whole treatment course. You take it for 2 days. You might get better. You stop taking it. And the infection comes back, maybe worse.
Stronger.
Now resistant to amoxicillin. So it's not benign. People do it all the time. They take like a a 2 or 3 day course. It's not the full 7-day course you need though.
Yeah.
So, yeah.
Yeah, the other thing is people will be like, oh, I took we get a lot of elderly people with high blood pressure that come in, right? And their blood pressure is running high, so they take their medication that they're supposed to take, and then they wait like 15 minutes and they take another dose because it didn't come down. And that's not exactly similar to this, but that's also dangerous, right? Because like a medication is going to take a few hours to work. And so you got to give it time. And that can also be dangerous where if you're doubling up on a beta blocker or some other medication, like once again, it could bottom you out. It could slow your heart rate down. You could pass out. And it is a common thing that we see.
Yeah.
Yeah.
I do with, when I worked in palliative care, we had a lot of pain patients. And cancer pain is horrible. Right, it's really difficult to control, and I had a few patients that would be like, I took, and they would admit it, right? I took XYZ's other pain pills, right? And then we would always have to re-educate them, like let us know, like we're not going to judge you, right? Your pain, you have a legitimate source of pain, like, but at the same time, we need to know because if God forbid something bad happened. We need to, if we have to give you a reversal agent or something, we need to know what to give you.
Yeah.
In case of emergency. So, yeah.
Yeah. I think another thing that's important also is, like if someone has high blood pressure or high cholesterol or diabetes, and you show up to the ER, one thing I've noticed is a lot of people be like on the medication maybe for a month or 2 months because they were like in the ER, they say their primary care doctor, and they put it on them, and then the refills ran out. And sometimes they'll just stop taking it because they think it like treated it. And I think that's like that falls on us, right? It's an education issue. We need to educate patients on like, this is unfortunately going to be something you need to take for your life.
Yeah.
But they'll stop, and then everything will go back to, being hyperglycemic or having high blood pressure and whatnot. So that's one thing that I see commonly. And then the other thing is if you go to a doctor and you have like these diseases, like if you're on a blood pressure medication, you still have high blood pressure. And a lot of people will be like, I have no medical conditions. And then I'll ask, what meds are you on? And they'll tell me like a diabetes med, a high blood pressure med, cholesterol med. So it's like you have those. They're well controlled because of the medication, but your doctor still needs to know because like if you're coming in with chest pain and you have those conditions, that puts you in a high risk category. I might keep you in the hospital versus sending you home. So I think that's another educational point.
Yeah. I mean, honestly, I have been advocating for this for a while just because, as an outpatient nurse, we did do a lot of intake. But I'm like, please just bring a list of your medications. Just keep it current, keep it on your phone or something. And I was like, this scene is a perfect explanation of why. Because, you could, something good bad could happen when you can't speak, and your doctor knowing what medications you're on, it makes it easy, much easier to identify potentially a source of, what the issue is. So,
yeah.
You just make an AI app. It scans your picture, makes a list for you. How many times you take it? What you
oh
take
my
it for.
God, yes, that sounds great.
You got it right
And
there.
all the free time you have.
Easy to use, man. Just take a picture. It does it work for you.
Definitely.
Yeah. And then make sure to cut this guy in.
I know. No one take that idea.
Yeah.
I claim that.
We'll edit it out. So
Yeah, no, that's like that's such good advice. Like we get unconscious patients, and like honestly, add who your cardiologist is on there. Obviously, have your emergency contact on there. All of your meds on there. Because a lot of times we'll have someone that comes in and we'll be like, they're really sick. They have like maybe like terminal cancer. They may not want to get intubated, but we can't talk to them because they may be altered. And we're like, well, does a family member know? Maybe they discuss those things with them, but unfortunately we can't get a hold of family. And then we have to intubate them. We have to do everything. And that may be against their wishes. But having all of those things, like you said, listed out makes sure that we in the ER or you can acknowledge those wishes.
I think it also helps because how many times have patients come in and be like, oh, I take a small blue pill. I'm like,
oh yeah. If
you understood how many small blue pills are out there, and I think patients understand also that, drug shortage and whatnot, like the pills change in size, shape, and, color. So going by those characteristics, to identify medications, obviously not ideal. So again, lists, make a list of your medications and have it current.
Yes, 100%. Any final thoughts on you for this clip?
Yeah, don't take other people's medications. Don't take meds not prescribed to you, I should say.
That's a good good frame of thought to go by. Take only your prescribed medications. Okay, final clip.
in here.
Or she's being abused.
That too. We'll find out more when Dad shows up.
Yep, if he shows up.
Chat for a second. I can fill you in where we are. Hey, Jesse, do you want to keep Kylie entertained for a few minutes while I borrow her dad? We'll just head down to the family room. It's a little quieter there.
Why do I gotta talk to a social worker?
Anytime a child's injured, we have some standard questions that we ask parents and caregivers.
Good, that's fine. Great. Ask me here.
Well, we noticed some bruising on Kylie's body, some old, some new on her back and legs. Any idea how she got those?
Yeah, soccer. She plays for a club team. They're, little girls, but they play like they're in the Hunger Games.
Well, I understand that you and Kylie do a fair amount of roughhousing.
What? I'm sorry, are you fucking kidding me? Where are you going with this? Are you saying that I hurt my daughter?
Mr. Connors,
Oh,
nobody's
no.
saying that.
Gina!
Okay, Mr. Connors?
Just Gina!
Sir, take a breath.
Gina, what did you say to them?
Nothing. I said that you're a great dad.
Okay, what else?
That you guys like to wrestle.
Jesus
What?
Christ.
They wanted to know where all her bruises are
Who
from.
the fuck are you to talk about me and my daughter?
Who the fuck
Yeah,
am
that's
I?
what I'm asking.
Who the
Hey,
fuck
big
am
man,
I?
take one more fucking step.
Hey,
I
that's
dare you.
enough. You need to
Whoa,
calm
is
down.
that a
Everybody,
threat?
hey, everybody, back the fuck up!
Stop! Kylie's platelets are only 9,000.
What does that mean?
It's not what we thought. It's probably ITP.
What the hell is ITP?
Well, I chose this because I think this is like something that very likely has happened to all of us in the ER at some point, where the concept is anchoring, right? Where you think something is happening and you anchor on it. And even though there's like unlimited possibilities of other things that could be happening, you just find it internally easier and more convenient to say, hey, this is happening and I'm going to stick with this. And then I'm going to put everything else into motion to kind of prove that, essentially. And it's what we're taught in training not to do. But especially in an ER where we see a ton of patients and it's really busy, sometimes it's almost easy to do. And so all of us, when we're practicing, have to kind of break ourselves out of that pattern of like, you see something and honestly, 90% of the time, it may be true. 95% of the time, it may be true. But you have to consider the other things it could be. And in this case, obviously, if I was in her shoes, I would probably be wondering the same thing, right? Kid with various stages of healing for bruises, here with like not a parent's like a girlfriend or whatever the case may be. That's like another almost red flag. Mm-hmm. And this is, I think, a good reminder to whether you're a resident, a nurse, a attending physician who's been doing it for 30 years, that making sure that we're asking ourselves, what else could it be? And then do you need to get the test to prove or disprove that?
Yeah, I think, first of all, this scene, Santos is my least favorite character. And I think this is kind of a stark change from her last season. I mean, we've always known that she's been a strong patient advocate, a very vocal patient advocate, right? But the last season where, she suspected that her patient was abusing his wife, she was so bold and forward about, approaching him, even though he was sedated. But in this scene, I don't know, for some reason I was like, she didn't follow through. She didn't take, I don't know, is it your guys' jobs as physicians to like take account, maybe like, this is what, because I feel like she just let the girlfriend take the whole fall for this.
Yeah.
Right? But like, I don't know what your role would be like in the ER. Would you say like, this was standard protocol, blah, blah, blah. Because I feel like this was such a stark change, right? She's such a strong patient advocate, and all of a sudden, when being confronted, she's just like,
Yeah. Well, I think, first of all, anytime you suspect anything like this or psychiatric or anything, you have to medically clear the patient first.
Sure.
So realistically, like, obviously you're thinking those thoughts, but like, I would want to take a look at the labs. I would want to get x-rays, right? Like, even if you are suspecting like abuse or something bad, you need to say, hey, this patient didn't just have bruises, they had maybe like a fracture. Or, they had blood work that showed, they did it here. I think part of it was back where they had a urine that showed blood, which could be signs of like internal bleeding and whatnot. Did you investigate that further? And so you almost have to like build, in my opinion, like a full case. And then once you feel like you have enough or don't have enough, then you take the next step. Now, of course, you probably want to get the social worker involved and whatnot. But before you especially confront like a dad and whatnot, you have to have more information, in my opinion, before you like make that accusation.
Sure.
And then you, like you said, she kind of backed off and she just kind of let the social work lead. At the end of the day, you're the doctor, you're the physician, you're the one who made the call. You have to like let the patient know or the parent know like what you suspect, what your reasons are for doing that. And you can't, like you said, shy away from that responsibility. You can't be like, oh, now that it's uncomfortable, I'm going to let the social worker handle it or the charge nurse handle it or whatever the case may be.
Yeah, and also I feel like she realized she was wrong when the playlist came back too. She kind of like, just going down the wrong pathway of what was going on. But I agree, you get social worker involved, you try to rule out any medical causes, but you don't want to just accuse anyone of abusing their kid. It's kind of something serious that it's kind of a difficult conversation to have with a parent if they're not doing it, to have them to be wrong. So she played it kind of right in some aspect, got the social worker involved, but when she was wrong, I guess she kind of just, I don't know, maybe she just felt embarrassed. She didn't get the diagnosis correct. She was more so embarrassed too as well.
Well, this is like her first big loss, right? Like you said, she had a right call there. She had the right call in Langdon, essentially. Yep. So I'm sure she's feeling confident. She's like, I know everything. I've been right with my gut, and I'm right here. And
she's second year, right?
She's a second year now.
This when you're most dangerous. Because the first year you don't know anything, you learn everything. The second year is like when you're the most dangerous because you know enough, but you don't know everything. And that's when like you are seriously like the most dangerous person your second year residency.
I mean, she was gun hole first season too. Like, you know, I didn't like her then, but.
Well, in the last episode, we talked about gunners. She's definitely a gunner.
Oh, definitely, definitely. When she told, I can't remember her name, the like head surgeon, being like, "Oh yeah, I'm going to be in your like."
Oh yeah,
mother. I forgot the mother's name.
She was like, "I'm going to be double certified."
Giavati, right?
Yeah, doctor in surgery and emergency medicine. I was like, no one is that. Like that's just like an idiotic thing to say. Maybe there's like 5 people. Maybe.
Back to your original point about anchoring, it happens in oncology a lot with patients, right? They think, especially patients who are, in surveillance, right? Yeah. They think that they have these symptoms, right? They think the only thing they could possibly think is the source of those symptoms is their cancer coming back.
Yeah.
And we do a lot of, reassuring and, and again, like, we need to get your scans, right? We can't do anything. We're not going to act on anything because sometimes like we need to start treatment, do all these things. But again, unless we have like actual data, with scans, imaging, or lab work, whatever, we can't really act on it. And it's a lot of back and forth with that, especially with my breast cancer patients. But yeah, I feel like, scanxiety is a big thing for them, specifically because of, they just think that everything is their cancer coming back. And how do you say, how do you encourage, like, assure them that it's not without, the data? So.
Yeah. And it's like that in the ER for everything, honestly. Like someone's had a heart attack and they come in with chest pain and they think it's a heart attack. And it's easy for us to think like, oh, it's another cardiac event, but could it be like a pleural effusion? Could it be a blood clot? Yeah. Could it be like a million other things that can lead to chest pain? It could be. And that's what you just have to kind of keep, all of us have to keep pushing ourselves to be like, okay, you got to think about the other things and whatnot. The other thing, I think historically, and it still happens today, is when you kind of brought it up earlier with pain management, chronic pain patients who may have, back injuries, cancer, things like that, they come to the ER and they're in pain, and it may be like their 10th visit that year or something. And it's, once again, it's easy for us to anchor and say, oh, they're just like seeking more meds. But like, are they in pain because they have like a worse infection now, or their cancer spread and now they have like a spinal fracture because of it? Like making sure you rule all of those things out. And then at the same time, there's a reason for their pain. And so not anchoring on them being drug seeking, but like just once again, considering the full picture and whatnot.
Yeah, I think a lot of my job is, doing triage, but over the phone. Which is hard because you can't see the patient. You have to rely on a lot of your, assessment skills and knowledge, especially with pain. Pain is a very vague symptom. And a lot of the times, with back pain, it's, a surefire signal of, cord compression.
Yeah.
And getting a patient to go to the emergency room for back pain, especially if it's something they've had before, is so difficult. But it's like just letting them know, like, it could be a lot of other things, but this is a big emergency, right? Like this is something that you need to seek treatment for. We can't just, we can just throw pain meds at you. That's fine. But we're just putting a Band-Aid on the problem. So.
Yeah. Any other thoughts on this for either of y'all?
Yeah, I mean, anchoring can be a dangerous thing. You keep thinking it's like you said, some cardiac, some GI, or back pain. We keep thinking it's the same old thing, and we're missing something else. Anchoring can can get you in trouble. You think it's like a heart attack, maybe having a dissection. You take them to the cath lab or give them like any ED, like a heparin or something like that, and then their blood out and end up hurting them. So anchoring's a thing you got to look out for. Be aware of in the medical.
I think warehouse healthcare workers are guilty of it too, right? How many times, well, at least in my field, I'm like, I have a symptom, like, oh my God, it's like cancer. Like, I'm like what? So.
Yeah, you always think the worst.
Yeah,
definitely.
for sure.
Yeah. What are you looking forward to for the rest of season 2? I mean, we're only like 3 episodes in, so where do you think we go from here?
I am looking for. I keep forgetting that it's like July 4th, right? I'm like expecting to see like digits lost, but it's only 8 a.m. Or 9 a.m. right? So it's a little bit early for those accidents. But I'm excited to see what the massive quote unquote trauma is going to be. I think it's going to be like some cyber attack, but
because they like showed that in one of the promos, right? Like a cyber attack where like the whole hospital computers go down and whatnot.
Paper charts.
Yeah.
I feel like there's nothing more like unnerving when all of a sudden everything goes black and you're like, oh my God, like you can't pull, you have to go back to like quote unquote like the dark ages, right?
Yeah.
And I always freak out when I don't have access to like my EMR or anything like that, and I have to like, how am I gonna get my meds? Like it's basic nursing, right? You just have to do your thing, but so.
Have either of y'all ever been in a cyber attack situation? No.
We
don't want to be.
Yeah, same.
It wasn't like something happened, but at my hospital we lost Epic access for a day.
Yeah.
And
it's as good as a cyber attack. It's pure chaos, yeah.
And I think they elevated like cyber attack like security level to like the highest one, like level 5.
Yeah.
But it was like not a planned outage. And like I have great managers and they helped us through everything, but it was just like we do infusions upstairs, like chemo infusions, and the fact that they were still able to do all those infusions will require a lot of monitoring, a lot of communication between nurses, physicians, pharmacists. The fact that they were still able to get through and give the patients those medications safely was pretty remarkable.
Yeah. Yeah, I even have Dragon, this like a dictation software that we use to, write our notes, or AI scribes or other, things. And it goes down for maybe even like half a shift. And I'm like, I cannot function. So I can't even imagine what like a full on cyber attack then these usually last for like a few days or a week or whatnot. They're not like a 24-hour thing. So, and they've happened at many hospitals in our country. It's crazy. Like I couldn't imagine what that would be like.
Yeah. I guess we'll see soon, huh?
Yes.
That's most of the medical stuff. I'm really interested in like the things they do outside of medicine with lengthening with the pills, or with the the hospice of the advanced directives in the first. They do like a lot of good social stuff, even with the delivering the cancer news. They touch on that stuff a lot. So I'm wondering what they're going to put that in the rest of the season as well. How that's going to play out.
Yeah.
Some of those things.
Yeah, because and I feel like right now they've done a good job of kind of planting the seeds for a lot of the social things. But I feel like these aren't the end of the stories for either the cancer patient or this patient. Like I feel like there's more threads to be pulled. And then I think I'm personally giving it, this is episode 3. Like I think 5 or 6 is when like the big explosion happens. That's my prediction. Like something where like
12 o'clock then 5, episode 5.
Not like the big one, but like at least something more intense.
Yeah, maybe like a computer goes down. Like, what's going on?
Yeah. It's like the computer goes down and then it's like 2 hours left in the shift, and like we almost survived this, like last season, and then like the craziness begins.
The other hospital went down already. It's the nearby hospital.
Oh yeah, the end of this episode.
Yeah, we don't know what happened to it, but the hospital went down.
Right.
Yeah,
they're diverting.
It's probably a cyber attack that's about to hit this one.
What do you guys think of the new attending?
We talked about that last episode. I mean, she's fine. I mean, I like her. I mean, people may give her a hard time. She's kind of assertive, but I feel like from me, if I was a resident, I don't know if I would enjoy working with her, but she has what she wants to do. She doesn't give you like any free or leeway to kind of do your own thing. Robbie's kind of like, what do you want to do? And he'll just like, okay, cool. Or correct it if it's wrong. Well, she's kind of like, this is what we're doing, and answer for you. But I don't have no problem working with her. I've worked with people like that in the past. She's fine.
I think how she interacts with the residents is totally fine because she's like teaching them, guiding them, mentoring them. I don't like how she interacts with Robbie because like she's an attending, he's an attending. He does things his own way, she does things her own way. you shouldn't like we work on shift together, right? I'm not gonna kind of come in and be like, hey, Dr. Moore, I think you should do this, or I think you should see more patients, or we got a bunch of people checking and go up to like I'm not gonna do that, right? I'm gonna do my thing, you're gonna do your thing. You might be totally different about it. I mean, it might be totally different about how I do it. So I think like when it comes to like physician autonomy, once you're attendings, like you shouldn't like I feel like she is stepping on him too much. How she's acting with the residents, totally fine. You have to be stern. You got to be instructional. Everyone has their own way of teaching. Totally fine with that. I just don't like that Robbie her dynamic. What about you?
I think she's kind of, she's focused on what's ideal, right? The patient passports, like, trying to improve like policies. But Robbie's a realist, which is why I resonate most with him. Yeah. Because you have the by the book people, which is what this attending very much is, and then you have the people who adapt. Yeah. And I feel like I've learned, you learn from both kinds of people. Yeah. Right, but I feel like I learn the best from people who like Robbie, who like work on the fly, and adapting in different situations that don't appear in your textbooks. Yeah, there's only so much that school can teach you, but the floor teaches you everything. Yeah, and I think that's the nature of emergency medicine. Like we know certain things, but a lot of it's unknown, and you have to be the type of person who's like flexible and see a patient in a chair or a hallway bed, or, place a central line in a really tight room, and ideally it'd be a really large room. And there's just so many examples of emergency medicine where you wish you had it this way, but you can't. Or, you're short nurses on a night shift. Well, you're going to have to do with like 50% of nurses you should have had, and things are going to have to be different, right? Their documentations have to be different. Maybe, my expectations for how long things are going to take for the patients, like it may say on a sign, no, it'll take 3.5 hours for this visit. Hey, no, it's going to take 6 hours tonight because we're short nurses. We have like 3 traumas and whatnot. And so I think Robbie is, I resonate with him in that kind of way where he's like, we're going to get it done. We're here. And we will, make sure the patient lives and things happen the right way. Whereas I think if you're so rigid, it's going to be difficult being in emergency medicine, especially in like a community setting. At an academic center, time is of less like metrics are like less important, and you can take your time. And I think she would thrive in that type of setting, like in a level 1 academic center, like in Texas Medical Center. But yeah.
This is like a level 1 academic
I guess
center,
it is, but it seems different. Like I feel like a true level 1 academic medical center, like they'd have like 3 attendings on at once. Like the only reason she's there is because she's like shadowing him to train almost. But like the entire first season, he was the only attending there, which is like crazy. Like in a true academic medical center, you have at least 3 attendings on. Yeah, because
he has like what 3 or 4 residents at a time, right?
Yeah,
yeah,
so yeah. Because like the place I trained, it was like you had 3 pods, attending per pod, at least 4 residents per pod. You had APP, so you're like staffed to like the brim, and so you have so many resources. And then you have like the trauma pod that's separate from everything else.
I think she's just a representation of, kind of healthcare admins seeping down. Yeah. And, creating unrealistic expectations for patients. Yeah. And treating them more like, like clients versus patients. Yeah. Right? And Robbie is the one who kind of just like, this is how it is. Yeah. And, all the nurses and all the staff in the ER, they do the same thing that Robbie does. Like, this is not, this is the actual realistic expectations of what you should have. So that's why I kind of...
Yeah. I do think she's going to redeem herself. Like, I think like when shit hits the fan, she's going to do some stuff and you're going to be like, okay, she earned her keep. That's my optimistic hope there.
Maybe. Well, we'll see, because like I feel like a cyber attack would probably be the worst possible thing for her, because she's so used to like
her AI scribe's not going to work.
Yeah, she probably can't even type anymore.
Yeah.
I have a hard time typing now. I don't use the scribe so much.
Oh my god, I can't type. Like I said, when the scribe or dragon's not up, I'm like an old man. Any final thoughts?
No, interested to see what happens the rest of the 4th of July season. Thank you so much for coming on.
No, thank you guys so much for having me. This was so fun.
Where can people find you?
On Instagram and on TikTok. I'm that Spitfire Nurse M. So yeah.
Yeah, thank you so much for coming.
Thank you guys.
Yeah. Right, awesome. Till next time, folks.
Thank you.
Thanks for joining us for another episode of Cuts and Consults. It really helps us if you like and share this episode or any other episode with your friends.
And if you'd like to be a guest on our show, or if you have any feedback, please hit us up. Again, I'm Dr. Moore.
I'm Dr. Durrani, signing off.